All right, it's after 4 now, so we are going to get started, and I would like to welcome everyone today. I hope you're doing well and staying safe. I'd like to thank you for joining us for our webinar today on what everybody needs to know about cancer, key issues for the LGBTQ community. Perlmutter Cancer Center is hosting this webinar in collaboration with GMHC, and we thank Paul Olson for joining us today, and you'll hear from him in a couple minutes. Before we get started, please take note of the Q&A box on the bottom right-hand corner of your screen where you can submit questions for Dr. Quinn, and we will take questions at the end of the webinar. And I would like to turn the program over now to Megan Hasseltine, who is the Administrative Director of Patient Screening and Navigation, who is going to say a few words about the Perlmutter Cancer Center LGBTQ+ Cancer Prevention and Treatment Initiative.
Hi, everyone. I'm very glad that you all can make it today. I just wanted to take a few moments to introduce myself. I'm Megan Hasseltine, as Rachel said, and give you all who are not familiar with the Perlmutter Cancer Center a very brief overview of our organization. So we are a comprehensive cancer center designated by the National Cancer Institute. It's the highest level of designation that a cancer center can be awarded. We are an academic medical center, part of an academic medical center at NYU. We have a robust clinical trials portfolio and specialists located in Manhattan, Brooklyn, Queens, and Long Island. In 2020, as Rachel mentioned, we launched our LGBTQ Cancer Prevention and Treatment Initiative. The initiative has 3 goals. The first is delivering LGBTQ affirming and appropriate care. The second goal is building ties with the LGBTQ community and LGBTQ-centered organizations. So we're really excited and proud to partner with GMHC on these educational events and look forward to more collaboration. And the third goal is advancing cancer research for LGBTQ populations. So before I introduce Dr. Quinn, I want to turn it over to Paul Olson, who's the Chief Communications and Development Officer at GMHC, to say a few words about GMHC for those of you that may be coming in from PCC or other places but aren't familiar with GMHC. So take it away, Paul.
Thank you, Megan. Very proud to be partnering with the Perlmutter Cancer Center on this educational series. The last one was on smoking cessation in the LGBTQ community, and today is about cancer prevention. And we couldn't be more pleased to partner with you all. My name is Paul Olson. I'm the Chief Communications and Development Officer here at GMHC. As you may know, our mission here at GMHC is to end the AIDS epidemic and uplift the lives of all affected, but we look at that mission through the lens of a holistic point of view on health and well-being, and our services are designed to address the range of health and psychosocial issues that face our communities. And we know that health disparities persist in the LGBTQ+ communities and are caused by multiple factors. As a cancer survivor myself, I'm certain we will all benefit from today's discussion with Dr. Quinn. And thank you all for joining us, and Dr. Quinn for leading us today in this conversation. And now we'll turn the floor back over to Megan to introduce Dr. Quinn.
So hi, everyone, I'm back. It's my pleasure to introduce Dr. Quinn. We're very fortunate to have her today. Dr. Gwendolyn Quinn is the Dr. Livia S. Wan Professor of Obstetrics and Gynecology and Professor in Population Health. Dr. Quinn studies health outcomes of cancer patients to improve patient care and quality of life. Her research on how well oncologists understand the needs specific to LGBTQ cancer patients and survivors really has formed the backdrop of PCC's LGBTQ initiative. So I will turn it over to Dr. Quinn.
Thanks, Megan. Well, good afternoon, everybody. And so I'm going to talk about some
considerations for cancer screening and cancer incidence and prevalence. And I apologize in advance because this is maybe not the most interesting of topics, and there's a lot of medical jargon associated with it. So I look forward to your questions to help me explain it better in the future and to make sure that everybody understands what I'm talking about. So the number of people who are identifying as LGBTQAI+, and sometimes there's additional letters in that acronym, is increasing. People who have sexual orientations and gender identities that differ from cisgender and heterosexual people, I'm sure have been around forever. And it's not that the numbers of people are increasing, it's just the numbers of people who feel comfortable noting that identity are increasing. This is particularly seen in the most recent generation, which I can't remember now, if I guess they're Gen Z. So recently at NYU, the incoming freshman class, over 30% of the incoming class identified in some way as something other than cisgender and heterosexual. So the disparities that exist in this population, and I'll keep now referring to the population as sexual and gender minorities. I know it's not a term that people are familiar with and they might not even like it, but it is a research term to describe what, in other words, we might describe as the LGBTQAI+ population. And so it's coined by the National Institutes of Health and the American Society of Clinical Oncology, who recognizes this group as one that's experiencing health disparities and, in the case of cancer, has increased risk for cancer. So I want to say at the outset that all humans have cancer risk, and that this risk is a combination of genetics, which you can't do anything about. You got the genes that you got, but you can be aware of if you have risk based on a hereditary factor by knowing your family history, and behaviors. And so whether you are a lesbian cisgender woman who smokes or a heterosexual cisgender woman who smokes, you have the same risk. So I really want to emphasize that these behaviors are not because of who you love or how you identify, but it's just anybody who has these behaviors has increased risk. There are some behaviors that we probably should work on changing, such as smoking and substance abuse. But other behaviors we don't necessarily need to change. We just need to be aware of the association of those behaviors and their risk. So let me clarify that another behavior that we probably need to change is sun exposure. So sun exposure, substance use, and tobacco risk. So the majority of literature that we know about sexual and gender minorities in cancer care really does focus on risk factors, but it also really focuses on HIV/AIDS. And so we're really in the infancy stage of knowing what we need to know about how best to serve sexual and gender minorities in cancer screening, prevention, and treatment, and even end-of-life care, because we can't take what we know from the cisgender heterosexual population and assume it applies, nor can we take what we know from the HIV/AIDS research and assume that it applies. So the biggest takeaway message that my research and that of others has shown is that clinicians have poor communication skills or are uncertain about how to apply communication skills to be respectful and culturally sensitive, or the better term is culturally humble, for sexual and gender minority patients. We also know that it's a double-edged sword. So clinicians often don't ask about a patient's sexual orientation or gender identity, and patients don't disclose it. And there'll be certain things, for example, if you think you have a broken arm and you're going to the emergency department, maybe you don't need to disclose your sexual orientation to your emergency room physician, and maybe your physician doesn't need to ask. But in experiences where there's potentially long-term care, such as the need for routine screenings or if a cancer is diagnosed, for a treatment plan, where you're going to have a relationship that is important. And the reason that it's important to the clinician is because the clinician should know the whole of you, who you are, and you should feel free to disclose this to your clinician because it's an important part of who you are and may have implications for treatment choices that you may make, as well as support systems and who your support systems may be. But the problem is people wouldn't necessarily know to disclose this if there's nowhere on a form to indicate it, and a lot of practice settings don't collect what we call SOGI data, that's sexual orientation and gender identity data. So in the cancer arena, we're working really hard to change this, and we're working to kind of harmonize this data collection and ask the questions in ways that are respectful, but also that if we ask this question of our patients, then it gets utilized. So there's nothing worse than filling out a form with all of your information only to go into the exam room to get asked all that same information all over again, and then for someone else to come in the room and start asking you questions again. So that's a burden to a patient, and it's a poor collection of data. So data that we collect just to be stored away someplace is of use to no one. And another thing that our research has shown is that even when clinicians work in practice settings where SOGI data are collected, they don't know how to apply that information. And I like to tell this story that's, you know, somewhat humorous but also sad, that one of our faculty came to me and said, so we started collecting SOGI data, and I looked on my patient's chart, and I saw that she had chosen lesbian gay for her sexual orientation. He said, but I didn't know what to do with it. So I walked into the room and I said, so I see you're a lesbian. And, you know, obviously that didn't go well. He knew that it didn't go well, and he was asking for advice on, in the future, how to have that encounter go in a better way. So the barriers to care, to cancer care and screening, again, are twofold. They're both on the part of the healthcare system as well as on the part of the individual. So we know that healthcare professionals don't have a lot of knowledge of healthcare needs of sexual and gender minorities. And we know that some of them even have negative attitudes towards sexual and gender minorities. Our research and that of others has shown that clinicians tend to fall into three buckets. There are people who are very willing to and want to provide care for sexual and gender minorities, but just haven't received training in how to do that. And then there are people, and this is a minority, but they still exist, of people who have values-based judgments against them. And so we're trying to develop systems so that a patient never has to be in front of a physician who has those negative attitudes. And then the third group of clinicians, and this is very prevalent, is that they don't think they need to know the sexual orientation or the gender identity of their patients that they're treating, because they think that they're a good clinician and they treat all patients the same, and they don't need to know that. And so that's another group of people who need a different type of training than people who recognize that it's important but just have not received the training. We also know that sexual and gender minorities have barriers to accessing any type of health care, but particularly cancer screening, because they might not have health care coverage or they might not have good coverage. We know that a lot of people's insurance benefits don't cover mental health services or hormone therapy or even gender-affirming surgeries. And we know that because particularly older sexual and gender minority people have had a lifetime of experience, of negative experiences in a healthcare system, they're less likely to seek care when they know that something might be wrong, because they're afraid of being refused care or having a stigmatized or negative healthcare situation. So there's lack of understanding and trust in a patient-physician relationship. And patients can also fear that if they do disclose their sexual orientation or gender identity, that their confidentiality may be breached in some way, or that they fear that they'll get less care or substandard care. So one thing that all patients should be aware of is, even if you are seeking care in a system that collects SOGI data on an intake form, you can always ask your provider not to have that documented in your medical record. And it could be something that you just disclose verbally to your clinician if you don't want there to be a documentation of this in electronic medical record. And as I've mentioned, it's probably quite common, maybe less so in New York than in other states in the country, where people don't have access to culturally sensitive resources and referrals. And so if you're going to seek, for example, cancer care services, and you pick up a brochure on screening and you see a white man and woman on the cover, you're probably likely to say, oh, this place might not be for me. You know, I don't see people who look like me here. So the bottom line is that we just don't know enough about cancer in LGBTQ or sexual and gender minority people. We do know that there are 7 cancers that, according to a systematic review that we conducted, are more prevalent in this population, but it's really very poor data because the way that we collect data in general about cancer risk and prevalence comes from cancer registries that are called SEER sites. And these SEER sites do not currently collect any information about sexual orientation or gender identity. So when we collect these data, we kind of have to impute it from other sources, and that's not the best quality way to collect data. So some cancers, risk factors are more common, and some of the reasons that they might be more common is because people don't get screened. And this is maybe because people believe, because there's certain myths and misperceptions or low health literacy, they don't think they need to be screened. So lifestyle factors such as drinking, smoking, and being overweight are the #1 factors that all humans have that are correlated to increased cancer risk. So as I said at the beginning, LGBT people are not at greater risk. They just are more likely to have more drinking, smoking, and weight issues or BMI issues than the cisgender heterosexual population. They're also less likely to receive preventive medical care, say, for example, when we get to HPV vaccine, because some clinicians are not aware of the recommendations for HPV vaccine based on people's sexual orientation. And mostly our data has shown that, and these figures are on the slide here, that 60% of oncologists don't feel that they know enough to treat lesbian, gay, and bisexual people, and 80% don't feel that they know enough to treat trans people. So the barriers to cancer screening from the patient side are, again, that they're accessing a healthcare system that often might not be culturally sensitive, and that can be a #1 barrier. And as I mentioned, many oncologists in particular, with the multiple studies that we have done, just don't feel that they need to know this about a patient, even if they are a sexual and gender minority person themselves, because they think they just are good doctors who treat all patients the same. And then we know that in a recent survey, 28% of transgender individuals delayed seeking medical care when they knew there was a problem because they feared discrimination. So now we'll talk specifically about the cancer risk and the associated screening. So the biggest cancer risk among all people under age 50 is HPV. So HPV, human papillomavirus, is a virus that is sexually transmitted. It is probably the only cancer prevention tool we have right now in the form of a vaccine, of the HPV vaccine. We know that it's the primary cause of cervical cancer in people with a cervix and genital cancers, and it also is associated with head and neck cancers. So HPV can be screened for by cervical pap smears. It can also be screened for by anal pap smears. Anal pap smears are currently only recommended as standard of care for people who are HIV positive, but there are other groups of people, such as men who have sex with men, who would benefit from anal pap smears. But since it's not a standard care, and since it's a standard of care and not recommended by the preventive task force, it may not be covered by insurance. So it's estimated that 61% of people who are HIV negative and 93% of people who are HIV positive across gay and bisexual men have anal HPV infections compared to 50% of heterosexual men. But even heterosexual men may be engaged in penile anal sex. And what we do know about HPV vaccine is that in about 60% of people, the infection or the virus clears on its own. So if you have not been vaccinated, there's still a 50% chance that it will clear on its own. But as you get older, the likelihood of that clearing on its own is less and less likely. So it's why the HPV initial vaccine recommendations begin very early, starting at age 9 to 10 years old, for all human beings, regardless of their sexual orientation or gender identity. So this is what the cancer incidence rate looks like that we know of now, and this is really just specific to HIV positive people. They have the highest rates of anal cancer, and in the general population, it is much less. So as I mentioned, the HPV vaccine is available and in most cases covered by insurance for people aged 9 to 45. So the recommendation of 45 is for men who have sex with men and women who have sex with women. And many people that I work, many oncologists that I work with recommend that men who have sex with men or any person who has penile, anal, penetrative sex, that they get the vaccine regardless of where they fall in this age category. They may be older than 45, and even if it is not covered by the insurance, it can be at least received at a lower cost through public health departments. But we know it's much less common for pediatricians to recommend HPV vaccine for people who are assigned a male at birth. While 25% of gay and bisexual men are knowledgeable about the relationship between HPV and anal cancer, that means that 75% are not. And it is, like I said, the vaccine prevents 90% of HPV-related cancers, which would include anal cancer and head and neck and cervical cancer in people with a cervix. I mentioned this already. So this is just, some specific data about the number of women who have sex with women or bisexual women who have a cervix who have actually had cervical cancer screening, and the majority are not. And this is likely, again, to be related to knowledge. So people who identify as women and who have a cervix and who are only having sex with other women with a cervix don't think that they need pap smears or cervical cancer screenings because they think that that cancer is only attributed to women who have sex with men, which is not true. But there's often a lack of information in the younger generation. And we also know that the majority of people, whether they identify as lesbian, bisexual, or transgender men, would prefer not to go to an OBGYN to get their cervical cancer screening. They would prefer to do it at home through self-sampling, which is an option in some clinics. And you can certainly imagine that if you're a trans man, with a beard and dressing as a male, that you would not feel comfortable in an OBGYN clinic with, pregnant women and people who are presenting as very feminine. And some places have actually created alternate clinics for trans men for cervical and pap screening. So, for example, there's a place I know in Miami that Wednesday nights at 7, from 7 to 9, is for trans men, and then they feel more comfortable going that, knowing that there'll be other people like them in the clinic. This is also just some specific data on, again, lesbian women fear discrimination, and they perceive less benefit from screening than heterosexual women. And there aren't any specific guidelines for cancer screening that are unique to lesbian and bisexual women, so they're recommended to be screened at the same way of same rates and same timelines as heterosexual women. Moving on to cancers that affect people who have breasts and cervix, the recommendations are that, and this says women, and we have a long way to go to kind of change the gendered language that is associated with cancer screening. So the American Cancer Society, these are their recommendations, and they've used the term women. So women age 40 to 54 should have a screening baseline mammogram. And again, depending upon family history, this may vary. If you have a family history of breast cancer, it doesn't have to just be from the maternal side. It can also be on the paternal side. It can also be if there's ovarian cancer or prostate cancer on both sides, then your screening recommendations would begin at an earlier age. And then women age 55 and up are recommended to have an annual screening, and that should continue for at least 10 years or more, depending upon if any abnormalities are ever found at any time in that 10-year period. Screening of the cervix is recommended to begin at age 21 and should be continuing for age 21 to 29 every year, regardless of sexual orientation. And then if there have been no abnormal PAPs during that time, then screening can be done every 3 years up to age 65. Women who are older than age 66 and who have had 3 consecutive negative PAPs and HPV tests only need to be screened then every 5 years. And people who have had a total hysterectomy do not need cervical cancer screening. So mammograms are definitely life-saving. They're not fun, they're not comfortable to have, but definitely early detection can save lives. And even breast cancer that's detected at a late stage, we have tremendous success with treatments and potentially even cures. So what does cancer screening look like in transgender, non-binary, and gender non-conforming people? So again, this is an area where we don't have good data as to whether or not they have an increased risk or decreased risk based on specific organs. So right now, the general rule of thumb is if you have it, you should get it screened. But there's also an issue with health literacy, and this is not unique to the LGBT community. It's in all human beings. I can't tell you the number of cisgender women who don't know what fallopian tubes are or cervix, or even if they've had a hysterectomy, that they don't know if it's been a complete hysterectomy, meaning that the ovaries and fallopian tubes as well as the uterus was removed. So it can be challenging sometimes to talk about screening with really precise medical terms because people just are not aware sometimes of what's in their body. So for trans people who have breast tissue, mammograms are still recommended. For trans people who have a cervix, cervical cancer screening is recommended. For people who have been on hormones for a certain period of time, aortic aneurysm screening is recommended, and bowel screening or screening for screening for colorectal cancer is recommended for all human beings, and it's based on age, and I'll talk about that in an upcoming slide. We know a little bit about hormone use and whether or not it has increased risk, but again, we don't know a lot. We don't currently have any registries of transgender people and or non-binary people and hormone use. We're beginning these things, and we're beginning to track things to see if they have more risk or even less risk based on this, but pretty much prostate cancer screening is recommended for anybody who is born with a prostate, and most people who have gender affirmation surgery male to female, typically the prostate is not removed, so the prostate still needs to be examined. There might be some increased cardiovascular risk based on hormone usage, and so that screening varies depending upon the type of hormone and the length of time that the person has been on hormones. Estrogen does create an increased risk of diabetes and cholesterol risk, and so on a case-by-case basis, people need to consult with their clinician about whether or not they have need for increased screening. So again, cancer screening in the trans community is based on the person's age and what organs and tissue are present. So even people who have had mastectomy, if depending on the type of mastectomy that they've had, there are still recommendations at age 50 to have some screening of that tissue. So now moving on to cancer risk in gay and bisexual men. So cigarette smoking tends to be more prevalent among gay men, as is sun-seeking behavior. So that's tanning behaviors, whether it's actually tanning in the sun or tanning in a tanning booth. And so that does create increased risk for lung cancer for the smoking and skin cancer for the tanning behaviors, as well as those who have not received HPV vaccine. There's increased risk of anal cancer. But we don't have good consensus on whether men who have sex with men should undergo routine anal cancer screening, which would be anal pap testing, unless they are HIV positive. So all human beings are recommended to have colorectal cancer screening starting at age 50 up until age 75. So if you have a colonoscopy, which is the gold standard recommendation, at age 50 and there are no polyps and nothing is detected, then you only need the colonoscopy every 5 years if there's no family history. But some people don't want to do colonoscopy, and it is done under sedation, so some people are not eligible for that. So the recommended FIT testing, or IFOBT, which is fecal immunochemistry testing, is an alternative. This is basically a kit that you are given and that you do at home, and you take a little smear sample of your poop and you send it off to a lab for testing, and that is recommended to be done every year. So lung cancer screening is recommended for people with a 30-year PAC smoking history, starting at age 55 and up to age 80. A lot of people want to have this done, but they find that they don't actually meet the PAC year smoking history. So even if they've quit within the last 10 years, maybe they didn't smoke a pack a day for 30 years, which is the requirement. They smoked half a pack a day for 20 years, but they still have concern and want to have it quit, want to have it be tested. And so you need to negotiate with your clinician about how to record your smoking history in order for insurance to cover this. And insurance does cover this for people who meet the screening guidelines. If you don't have insurance, there are other ways to get this covered by talking with your clinician or talking with a clinic about how to access low-dose CT. Skin cancer screening is recommended for all human beings. These are just some ugly pictures of what melanoma can look like. Not all skin cancer is melanoma. There's lots of different kinds of squamous cell. But basically, everybody age 30 and over should have an annual skin cancer screening. And if you ever see anything that looks suspicious, or something like in the slide here in E, something that started off small but is growing rapidly and looks different than a traditional freckle that you have, it's good to get that checked out. If you've had a lot of sun exposure, or if you live in the South or in California or an area where you have sun exposure year-round just from going outside, it's even more important to get a skin cancer screening. So men who have sex with men do have a higher risk for skin cancers, which is not always related to sun exposure, but it can be related to exposure to other viruses versus skin infections and things like that. So it's important to talk with a clinician about what your risk may be. And then there's also prevention of risk with PrEP and pre-exposure prophylaxis. And I won't talk a lot about that today because it's not necessarily related to skin cancer screening. But depending upon your use of some of these treatments and medications, you may have increased risk for some cancers and decreased risk for other cancers. And this is a really busy slide, and it's really about sexually transmitted infections and what people's risks are based on the type of sexual behaviors that they're engaged in. And it's not fun to, name all these names and go through all these data. I'm happy to share these slides if anybody wants to talk about it in more detail. But there are bacterial infections, syphilis, gonorrhea, chlamydia, MRSA, and meningococcal disease, which are not related to cancer and are treatable, but are increased risk for people. And it's not even about men who have sex with men, it's people who have either receptive or penetrative anal sex. So the CDC and other public agencies have these recommendations for screening for sexually transmitted infections based on HIV status and the type of sexual behavior that a person is engaged in. So recommendations for HPV vaccine, I think I talked about this already. All humans are recommended to have this vaccine through age 26, regardless of whether or not they've had a prior or have a current HPV infection. And then the 2-dose series and the 3-dose series depends on which brand of the vaccine you're getting, and whether or not you are using PrEP. And we're also for people who might have an occupational risk based on clinicians who are working with people who are HIV positive. So just switching gears from talking about cancer and cancer risk and cancer prevalence, this is something that we really recommend for all clinicians, and we recommend that patients should be looking for these things when choosing providers. So you're really looking at what's the structure of the system in which you're getting care. Do you see a gender-neutral bathroom? If you see a gender-neutral bathroom, there's a good chance that the clinicians in there have had some training in sexual gender minority care. We also encourage practices to create rooming policies that are inclusive, so people can, if they have to have an inpatient stay, they can room with someone based on the gender that they identify with, not their sex assigned at birth. And also there should be human rights policies that are patient-facing. So you should see those in the waiting rooms. You should see those on the website when you're trying to schedule an appointment. And also we're trying to grow that systems within the hospital are also inclusive. So not only have a patient bill of rights that's easily accessible to patients on the website and in the waiting room, but the intake form collects gender identity, pronouns, preferred names. Systems hopefully have received the Human Rights Campaign Health Equality Index status. And that the intake forms also give you the option, if you don't want to put that down in writing, that you have the option to verbally disclose your sexual orientation or your gender identity to someone. That ID bracelets for inpatients should be representative of a patient's pronouns and preferred name, and that these IDs and designations be carried through. So there's nothing worse than going to have your blood drawn and you have an ID bracelet on that indicates your gender identity and your preferred name, and then your blood gets drawn and taken off to the lab, and then it comes back as inconclusive because your genetic marker doesn't match your gender identity. So hospital systems have a long way to go to create these integrated systems that are inclusive, but particularly hospitals like NYU and in the New York area are aware of it and working on it. And some trans and non-binary have suggested, some trans and transgender and non-binary people have suggested that they would never like to fill out a form that asks for their sex assigned at birth, that's not comfortable for them, but they would like to fill out, they would be comfortable filling out an organ inventory, which I think is a potential move to go to. But again, we go back to the thing that many human beings are unaware of the organs that they have inside their body. So we might not always get accurate information, not necessarily about reproductive organs, but about other things. So some people don't, they had their appendix out when they were 5 years old. They don't know if they still have it. They don't remember if they had their tonsils out. So it may not be complete, but I definitely am recommending it to some systems as a way to help make sure that we don't have as much missingness in the data in the electronic medical record. So this is just a list of some resources if you are seeking cancer care services, of ways to identify LGBTQ competent or culturally sensitive providers. And these are some additional resources of places that have patient-facing information about all types of health issues and cancer screening and cancer treatment. So I will stop here, and I am happy to take any questions, and I cannot see them in the chat, but I believe that somebody was going to.
Yeah, thank you, Dr. Quinn. That was a great presentation. That was very informative. And thank you also to Megan and Paul. And with that said, we're going to open it up to questions. So if anyone has a question, you'll see the Q&A box on the bottom right-hand corner of your screen. So feel free to type in any questions you have. Questions, anyone? All right, nothing yet. We'll give it another minute just in case anyone has any questions before we wrap up.
Oh, it looks like there's.
Sorry, I was muted.
Oh.
So I said if anybody has questions, I put my email in the chat, so feel free to email me with questions.
Okay, I don't see anything else coming through.
I see one question, Rachel. I think I do.
Oh, let's see. I don't see it on my end, Megan.
Okay.
Could you read it if it's on your screen?
I can't read it.
I see a question.
I got a thank you. There was one comment. I think it was a thank you.
Oh.
I see a question that says, what research needs to be conducted to determine a connection between cancer prevalence and sexual identity. And I would say the answer to that question is we need data repositories, whether they're, through SEER sites, which are the primary way that, so every state submits their cancer data to these SEER registries. And so if individual clinics and hospitals are not collecting SOGI data, they can't report it. And currently right now, SEER data does not have a place to record that demographic information. So we need to work on that at multiple levels, because if like I said, we're doing these like kind of imputations and these secondary data analyses to assume sexual orientation and gender identity. We don't have good, accurate. And I also understand that there's reluctance on the part of the patient population not wanting to know, why this is being asked. So this comes up with income all the time. So every time you fill out a medical form, someone might ask for your level of education or your income, and you're thinking, how is this related to the health care that I'm about to receive? And it really is, in those two cases, it's kind of bean counting. It's information that we need because we need to report that to the state. So we need to do a better job of helping the patient population understand why this is important information to disclose if they have the opportunity to it, because the right spaces are there on the intake forms.
Dr. Quinn, we have another question for you here. What are good resources for us to use on a day-to-day basis for best practices and guidelines for cancer management recommendations for our patients?
So are these patients who already have a cancer diagnosis, or are these screening for the general population?
It doesn't say. If the person who asked the question, yes, okay, screening.
Yeah, so I think the American Cancer Society has good guidelines and recommendations, and they actually have LGBTQ patient-facing materials about screening. And so that's one of the resources that was on the slide deck that I had. And again, I'm happy for this slide deck to be shared if anybody wants it. But they have the most up-to-date guidelines, and the guidelines are changing often. So just recently, the mammography guidelines changed in 2019. So it used to be that people were recommended to get a mammogram yearly starting at age 45 if there was no family history, and every year. And now they've changed that to 55. But part of the reason that those guidelines were changed is because if you've read Emperor of All Maladies, it really has to do with return on investment. So the cost to screen people age 45 to 55 versus the number of cancer incidences that were found through mammography versus the number of deaths did not prove to be cost effective. But for many women, particularly if there's a family history or if something abnormal is determined through self-exam, it's still important to advocate for yourself, for those mammograms. So to answer the original question, I would say the American Cancer Society has the best guidelines and recommendations and materials about cancer screening.
Okay, thank you, Dr. Quinn. That is helpful. And it looks like those are all the questions that came through. If anyone is interested in a copy of the PowerPoint presentation, you can send an email to cancerevents@nyulangone.org and request a copy. I'm going to repeat that again. That's cancerevents@nyulangone.org. Just request a copy and we're happy to send it over to you. And I would like to thank Dr. Quinn, Megan, and Paula for joining us today and all of the excellent information. And thank you for tuning in, and we'll see you next time.
Thank you, everybody.
Thank you.
Thank you.